This podcast is supported by our gold partner, Mundi Pharma.
Hello, Declan.
Hello, Renu. How are you?
It's been a busy EAU.
It hit. Yesterday, we posted a podcast from the Practice Changing Plenary with a big paper in Lancet Oncology, the Translate team, Richard Bryant and Alistair Lamb. And today, another one hot on the heels.
Just as impressive. Practice Changing Surgical Plenary up there.
It's already been such a big EAU annual meeting for those of you who are there or who are not there. We don't always get huge randomized trials, practice-changing trials being presented at this meeting.
With co-publications in major journals.
But we've had two of them back-to-back at this EAU, so it's testament to the quality of the work coming out of the UK, as it is again on this occasion.
And this one is extra special for us, isn't it, Declan?
It sure is.
Because it does involve our current fellow at Peter Mac.
It sure is. So look, today we're thrilled to welcome the team behind the Neurosafe Proof trial from the UK, including our current fellow at Peter MacCallum Cancer Centre, Dr Eoin Dinneen. Eoin, welcome to GUcast.
Thank you very much.
Good to have you in the studio.
It's lovely to be back. Am I a friend of the podcast now if this is my second visit to
Definitely a friend.
Definitely,
Thank you.
Usually the question is, do you have any merch? Did you get like a hat?
I didn't.
Oh, I'd
like
to. We would have fixed that. When you get the merch, then you're a friend of the podcast.
Yeah. Thanks.
But yeah, Eoin is here and he's doing a fellowship with us for 2 years. Actually, you're doing a 2-year fellowship here at Peter Mac. But your alma mater is UCL, University College London. And you've been doing your PhD on the trial that read out today at the EAU in Madrid, led by your senior author and mentor, Greg Shaw. And we're going to go to London in a second and talk to Greg and Ricardo, who are going to give us the real detail on the trial. But before we get into it, big congratulations. It's your PhD. You're the first author on the paper today. But more importantly, how are you settling in Melbourne? You've been here for a few weeks now.
Good. Melbourne is fantastic. Yeah. A little secret is behind the scenes here in GUcast HQ, my wife and children are in Declan's swimming pool. So that's kind of typical of how things go in Melbourne, which is mixing great work with having a great time at the same in the same spirit. And
Love
I must correct
that,
you, Ricardo and I are co-first authors.
Co-first authors, fantastic. So his kids aren't in the pool at the back as well.
Not yet.
It's a unique Melbourne experience.
That's it. We've got some stereotypes to live up to here, Renu. So he literally was, for those of you on YouTube, he was in shorts and swimmers a few moments ago with a 3-month-old and a 3-year-old. So shall we go to London and talk to the rest of the team on the Neurosafe Proof trials? So we're really, really pleased to be welcoming and congratulating Greg Shaw, Professor of Urology, Consultant Urologist at UCL in London, and Ricardo Almeida-Magana, who's one of the research fellows on the trial and co-first author on the trial as well. So Greg and Ricardo, congratulations and welcome to GUcast.
Thanks very much. It's nice to be here. Thanks for inviting us.
Yeah, thank you for the invitation. This is great. I'm a fan of the podcast.
Oh, great. Send that man some merch. That's what we like to hear. But look, what a big day today. We're posting this podcast just as the embargo lifts. You've just presented the work, Greg, and the papers hit the press in Lancet Oncology, no less.
Lancet Oncology, it's a huge deal.
Surgical randomized trial. So we'll get into the detail, but it's those of you out there who are familiar with the term Neurosafe will know that this is a technique pioneered, I think you'll tell us, in the Martini Clinic, where they do intra-operative frozen sections. So that's kind of the backstop to it. It's been going for years. We've all looked in envy at how they can do this, and they've reported certain outcomes that really look quite favorable. But nobody's done a randomized control trial to see if doing Neurosafe intra-operative frozen section during radical prostatectomy can lead to some meaningful outcomes. So Greg, we wanted to go to you first to tell us a bit about the background to, why you set up this trial, why you were interested in looking at this in a randomized setting, and, how you took on the challenge of doing a randomized control trial in a surgical setting like this.
Yeah, so we're pretty good at curing prostate cancer with robotic prostatectomy, but, unfortunately, we bring about side effects that are invariable. So patients experience a degree of incontinence and impotence. And since Walsh first described the cavernosal nerves running through the capsule of the prostate and found that by peeling them off, you could spare the nerves and allow some men to regain their potency. That's what we've been trying to do. But of course, when we take a prostate out, we want to cure the cancer. And so there's a balance between the amount of nerve sparing you can do and the perceived risk of leaving cancer cells behind. And I think the Neurosafe technique addresses that. I first came across the technique when I was training in robotic surgery at the Lister Hospital, and I was impressed. It made a lot of logical sense, but until now, all of the data behind it has been at risk of bias, and so we thought we'd take on the challenge and run a randomized controlled trial. And that's what we've been doing. And I've been very lucky. I've been supported by brilliant fellows, Ricardo, Eoin and Tariq Al-Hamouri have helped me get through this work and get it to where it is now. It's really exciting.
Amazing. What a great challenge to take on. And maybe, we'll go through some of the data. Eoin, we might go over to you for that. What were some of the key data from this trial?
Yeah, it's my pleasure to tell you, give you a whistle-stop tour of the headlines, as it were. So we recruited from January 2019 through to December 2022. So it's essentially 4 years, 2 COVID lockdowns in the UK. Yeah. 407 participants recruited at 5 UK centres. So it's genuinely multi-site. 190 underwent Neurosafe nerve spare guided RALP, and 191 standard. The average age was slightly lower than the UK average at 57, PSAs 9 on average in both arms. It's predominantly ISUP 2, 75% of the men are ISUP 2. All men, key eligibility criteria was good preoperative erectile function. All men went on to have a radiologist blinded nerve spare recommendation, and you'll see in the paper and table 1, I think it is, that the nerve spare recommendations are very evenly distributed, as you'd expect for a blinded randomized controlled trial. But then in the standard arm, men had nerve spare decision guided by that meeting and surgeon discretion. And in the intervention arm, men had nerve spare guided by the Neurosafe technique. Now we now know that the Neurosafe technique will put 43 minutes on your operation, on your robot-assisted radical prostatectomy. But also what it will do, in our study, it shows that there's a big increase in the amount of nerve sparing that you can perform. So the headline there is about 50% in the standard arm, 83% in the intervention arm. Fast forward through to the erectile function recovery, which is the primary outcome. We use the IIF5 score, which is also known as the SHIM. You might be aware. Yeah. And the adjusted mean difference was 3.18 in favour of the Neurosafe intervention arm, which was p-value under 0.001. That's the primary outcome. There's 2 out of the 3 secondary outcomes were also positive.
Hold on. There's so much to talk about in those primary outcomes.
Sorry,
it's just amazing. So just to go back again, so the whole idea of this is that we kind of always know that if we do more nerve sparing for patients, we're more likely to deliver better sexual function outcomes. But the limitation for us, or the balance, as we often say to patients, is yes, but if we're doing very tight nerve sparing, we might run the risk of leaving some cancer behind and having positive margins. And the idea is that having this intra-operative frozen section, and we'll ask you actually how you actually do that.
Yeah, I think that's important just for our listeners who are not familiar with the Neurosafe
adding the 40
technique.
minutes.
Yeah.
And actually, we've got a couple of good podcasts on it because we've been to the Martini Clinic and made some really good video podcasts of Neurosafe. We'll put the links in the show notes. But the idea being that Neurosafe gives you some confidence to do more nerve sparing, because you're going to really preserve the nerves and then do this intra-operative assessment of the prostate and so on to make sure that we haven't left some cancer behind. And if the frozen section says, you're too close, then we can go and take a little bit more tissue and make sure there isn't an adverse cancer outcome. But what you showed us, what you just said to us, Eoin, if I heard you correctly, and as Greg read out today, is that by using Neurosafe, you are going to increase the proportion of men who are having nerve sparing. That's the first part of it. And the second thing you said was, that leads to better sexual function. Did I hear you right on all that?
That's right.
Yeah.
And I'll say one other thing as well, that this is the first randomized control trial in the world to have demonstrated an improvement in erectile function in the intervention arm in a technical radical prostatectomy trial.
Impressive.
There you go, Renu.
So Neurosafe technique, let's if you could just briefly go through what it is that you physically do, the steps that you go through in the operating room. You've done a very aggressive nerve spare.
Yep.
You've basically extracted the prostate.
That's
and then
right.
what's your...
Yeah, so I was doing this for 2.5 years with Greg and some of the other UCLH surgeons as a surgeon, and I know that Ricardo followed in my footsteps by doing exactly what I'm just going to describe to you, which is take the prostate in a bag, walk it the 1 mile down the road, believe it or not, or in my case, I cycled with it in my rucksack to the lab. So then the prostate, the neurovascular bundle adjacent posterolateral margin, which is now nice and bald because of your nerve spare, has been painted on each side, separate colors. You cleave it with a straight blade. You mark the apex and the base, and then you do perpendicular transections, about 5 millimeters between each one. You pop that on a cryostat and snap freeze it, and that gives the tissue the rigidity that you can section it very thinly at about 5 to 3 micrometers, which then is popped onto the slide, stained with hematoxylin and eosin, and looked under the light microscope. That gives you the margin status. The margin status is conveyed back to the surgeon, who has the opportunity, if there is a positive surgical margin there, to go back and perform a secondary resection, thereby promoting the safety of that original, more aggressive nerve spare.
So I have a couple of follow-up questions, Eoin. What do you do in that time that you've sent this prostate out? You're on your bike.
He's looking up at Greg on the screen. Coffee time, you know.
Yeah.
What do you do in the OR?
Check your epic messages.
No, actually,
Don't say lymph node dissection.
I carry on with the operation. I mean, we're doing less and less lymph node dissection, but you could, of course, do that at this stage.
True.
But actually, I find that you can perform the reconstruction as long as you medialize your Rocco stitch, and you've got a pretty good anastomosis that you can move to the side gently so that you can perform the secondary resection.
Yeah.
Then it means that it cuts down on the time. So initially, when we were doing this, we were having to finish the operation, waiting for the results. But with experience, with understanding of the steps, we were able to get the time down. So we saw a decrease in time to the 43 minutes over the course of the study.
And my other question is, so let's say your pathologist has told you there is a small positive margin, and you're going back to resect more. How can you be sure that the place that you're resecting corresponds to this positive margin?
Yeah, so look, I don't think there is technology available to really allow us to identify where a positive margin has come from. But that's why we use the Neurosafe technique, because it necessitates, if you're going to do a secondary resection, you take the whole neurovascular bundle, you take Denon-Villiers across to the midline. So you've cleared the posterolateral aspect on that side.
And that was a decision that we took after the feasibility study, where we did permit partial secondary resection in the response to a small focal positive surgical margin, but we felt that that muddied the waters a little bit, perhaps, and also the oncological principle of this must be really sound. So collectively, we decided that it would be a full ipsilateral secondary resection of the neurovascular bundle, just for these reasons that Greg has mentioned and that you raise.
Very
And
good.
we'll come in a minute and talk about subsequent things like correlation between the frozen section and the final thing, and of course biochemical recurrence people will be interested in for the study. And we're going to come also in a few minutes and talk about the pragmatic challenges of doing intraoperative frozen section, because I know Ricardo has a whole bunch of other work, because I think as we hear today at EAU, everybody is interested in this. There's going to be huge headlines about this, but there's still a very big challenge in going to work tomorrow and saying, I want to do frozen sections on all my radical prostatectomies, and even if it's like the question of hopping on a bike, and even if there's a pathologist waiting, there's all sorts of problems, but there may be other solutions, Renu. The whole idea of this is really about intraoperative margin assessment. And this is, I think, kind of the Rolls Royce of it, doing a frozen section and so on. And now a randomised trial has shown us these benefits. But there are other technologies that, stay tuned, Ricardo and Greg will talk a bit to, and Eoin, that may help bridge the gap to say, right, if you can't do a Neurosafe, here are some other things that might help us achieve that. But on the point, we'll ask Eoin, I suppose, to talk about these other key secondary endpoints that we're going to talk about as well. You were going to rush into them, but I'm sure you're going to cover things like biochemical recurrence rate that we're all very interested in.
Predefined secondary outcomes were urinary continence recovery at 3 months using the ICIQ questionnaire, urinary continence at 6 months using the ICIQ questionnaire, and the IIEF6, also known as the erectile function domain of the IIEF, at 12 months. And the 3-month urinary continence recovery was a statistically positive secondary outcome with a adjusted mean difference of 1.14 in the ICIQ score. that difference was lost at 6 months, which is interesting, which I think goes with what we know from some of your co-Melbourne authors on the benefits of nerve spare for early continence and recovery, which doesn't last much beyond early continence and recovery, but still important to patients. And the IIF6 erectile function domain correlates quite closely to the IIF5 because it uses 4 of the same or 3 of the same questionnaire items of the questionnaire. So not unsurprisingly, that was also statistically significant, but to a larger degree because it focuses on the erections rather than a couple of the other sexual satisfaction questions. So those were the secondary outcomes that we tested for statistical significance. I know that the oncological outcomes are also important, but they weren't secondary outcomes as such. But we of course include them in the Lancet paper as our readers and your viewers will see.
I suppose on the sexual function side of things, Greg, these are the 2 key things we're reporting. We're hearing in your report today. Number one, you can increase the nerve sparing rates by doing a Neurosafe. Very significant. Was it 50% up to 80?
83.
Wow. I mean, it's
wow,
unbelievable. Yeah. With the confidence that Neurosafe is giving you to say, I can do better nerve sparing. Because the reason we don't do it all the time for everybody is because we're worried about positive margins. And number 2, it does translate into a more positive shim score. On average, was it 4 points?
3.18 in the IAF5 in the full analysis set.
So, Greg, my question to you is that a clinically meaningful benefit? Is that your take on this?
Yeah, so there is some data out there for clinically meaningful data for the IIF6, and our data approach that, but perhaps a better way of thinking about it. And, when we were writing the paper, we thought, what's going to demonstrate to patients that there's a benefit? And there's a nice histogram in the paper which shows the proportion of patients who've recovered their potency to the predefined thresholds over time. And the key data there is that at 12 months, almost double the number of patients will be experiencing no erectile dysfunction or mild erectile dysfunction in the Neurosafe group. So I think that sends a strong message, and it's perhaps more meaningful to a patient than saying you're going to score 4 points higher on a questionnaire.
Yeah, exactly. What do those numbers really mean?
Yeah,
absolutely.
A few other important points that we wanted to highlight, I suppose, in this, Ricardo, the biochemical recurrence rate. Tell us about that. And the positive surgical margin rates overall, I suppose, they're reported in it. But positive surgical margins and biochemical recurrence, what did you report?
So in regards to the positive margin rate, so Neurosafe has been described as a method to decrease the positive margins. However, as Eoin mentioned, we did a feasibility study, and to give that balance, we decided to allow for small positive margins to not translate into an immediate resection of the whole neurovascular bundle. So we basically had a tolerance for very small, low-grade positive margins on the Neurosafe. Yeah. So that meant that we actually saw a little increase in the rate of positive margins, overall positive margins. But if we focus on the ones that we know are clinically significant, that are related with a higher increase in the rate of biochemical recurrence, those actually decrease in the Neurosafe arm. And many of the margins were also not only on the posterolateral surface, we also have margins in the base and apex. So that may be a surprising result for some of the readers, but there's a reason behind it. And I think that allowed us to really push the boundaries of nerve sparing as in the way we did. And we believe this is safe for patients. And this is based on all the work that the Martini Clinic has done. As well, with the biochemical recurrence, we were very keen on getting these outcomes. We followed all patients. We have a high rate of data completeness in the follow-up. However, this is very early. It's only 12 months. We saw almost identical numbers in terms of biochemical recurrence and also in terms of PSA persistence. We saw a slightly higher rate of adjuvant treatment, but that was driven by, let's say, the pathology report being interpreted as being in a worse way than it actually is. So the follow-up of the patients was by clinicians, and sometimes they were referred to receive adjuvant treatment, and that happened in the initial phase of the study. And as the new evidence regarding the lack of benefit with adjuvant treatment percolated into the clinical practice, this tended to disappear.
That makes sense. Yeah. Ricardo, you did do some subgroup analysis. This may not be practical to do in every patient, but was there a particular group of patients that benefited from this more than the others?
Yes. So as Owen mentioned, we give a recommendation at the beginning for all patients. And we thought that the effect of Neurosafe was going to be driven by those guys that if they didn't have Neurosafe, there's no way they could have had neurosparing. So we selected that subpopulation. Obviously, that comes with paying a price in terms of power. But we analyzed the results in those patients, and they actually benefit even more from Neurosafe. So yeah, that's an important takeaway to basically, this is a time-consuming and resource-intensive intervention. So if we focus on those patients, I think that's where the money is.
And these are patients that you selected based on MRI results that you wouldn't offer?
Yeah. And MRI and biopsy.
Well, and we know this from the systematic reviews that show that Neurosafe will increase your nerve sparing.
Yeah.
So, but those systematic reviews show that these observational studies, they don't start from a nerve sparing status in the retrospective cohort of 0. They usually go from say 50 or 30% nerve sparing up to 98% following the introduction of the Neurosafe. So this builds upon that, and it also builds upon our observation whilst we were doing feasibility study and other work that oftentimes your MRI will get it absolutely spot on, recommend the bilateral nerve spare, and it'll be T2 disease because the tumour's well away from the posterior lateral margin. So there's limited benefit in doing the Neurosafe on those guys because they were going to get a bilateral nerve spare anyway. And this subgroup analysis demonstrates that beautifully because the IIEF-5 score is greater, the proportion of men who recover, the difference in the proportion of men who recover across the two arms is greater. Yeah. So as Ricardo rightly says, that's where the money is.
Yeah, absolutely.
And it's like, they call it a practice-changing plenary. This changes practice kind of almost instantly in our approach to it. And we'll get in a moment to the pragmatism of it. But Owen, in looking at the tables, you did manage to recruit a quite diverse population. And I know that's something that the group are particularly pleased about. Can you just tell us a little bit about that? These aren't all just, white British men, are they?
No, we are really proud as a group of prostate cancer researchers from the UK that we recruited 30% men from Black and Afro-Caribbean backgrounds, and 5% of men of our study population were from other non-white Caucasian backgrounds. Declan, you'll know because you were one of the authors on the Lancet Commission on Prostate Cancer published last year, that this was one of the key priorities for the future of prostate cancer research. The research that we produce has to be representative of the population of people that suffer from these diseases, and historically perhaps they haven't been. I think that this is representative of part of the populations that the hospitals involved in this trial serve. So in Northeast and Central London, we have large communities from very diverse backgrounds, but it's more than that as well. We were listening to our patients throughout the feasibility study, throughout the design of the full study. We were listening to the feedback that we were hearing, and we focus on outcomes that really matter to some of these populations that aren't your traditionally well represented in prostate cancer research populations. So funnily enough, if you do that, you'll get much greater buy-in and representation from amongst these patient cohorts who we're trying to reach.
Amazing.
I'm into that. Just awesome.
Love it. Greg, let me ask you, intraoperative frozen section, it's time consuming. It's not always available. What do you do? How do you deal with that?
Yeah, so, the issue with that became apparent when we were setting up the study. So, having written the protocol, got the funding, and starting off, we wanted to get UK centres involved. And we went out to a lot of centres, and we approached large academic centres, places that we thought would be able to get involved. And the repeated feedback for those centres who couldn't get involved was that they didn't have the support from their histopathologists. They didn't have the resource to be able to do this. And that exemplifies the point, this is resource heavy, and you need good pathology support. You need technicians cutting through the slices in real time, has to be organized. So, that feedback made us think, even if we show a difference here, if we've got centres in the UK, big academic centres that can't do this, what does it mean for most of the places treating prostate cancer? And so it got us to thinking, are there potential alternatives here? Is there something that could give you a similar readout, a similar intraoperative margin evaluation, without perhaps requiring all of the bells and whistles that are required for Neurosafe, that gives you a similar answer and a similar guide as to nerve sparing, and give you that confidence to do the aggressive nerve sparing that we evaluated with Neurosafe. And we've been exploring various different technologies. There's lots of new technologies coming into the fore that are relevant here.
Yeah, I mean, that's a good segue into that, isn't it? Because there's no doubt this is valuable, but it's how you go about it, I think, that matters, and how you can make it, cost effective and time efficient in the operating room.
I remember we had both Marcus Grafen and Alexander Heise from the Martini Clinic on 2 consecutive speaker tours down here a few years ago. And we brought the pathologists to the dinners. We fed them. And then we said, hey, can we do this on Monday? And even if we did the same thing now with the benefit of your randomized control trial, no, it's not going to happen. It's just not pragmatic. And in the Martini Clinic, where they, in the old building, they had 5 operating theaters, only doing one thing all the time, radical prostatectomy. So by 11 o'clock, 5 prostates have appeared. It's a production line, classic German industrial solution. You can see how they would make it work there. You can see how in an academic trial with huge effort and research fellows on a bicycle, you could make it work there. But Ricardo, I think what's exciting about this is that because the answer is going to be no for most of us if we go and ask our pathologists, or no, it's very, very difficult. Yeah. It is exciting that there are some novel technologies for intraoperative margin assessment. And you folk wrote a nice review paper on this in histology or histopathology. Histopathology. I remember looking at, these confocal microscopy techniques, the histolog machine, which we're about to investigate here, Vivoscope. We've looked at that Zeos PSMA PET CT thing, a little intraoperative PET thing. You take out the prostate and pop it in a mini PET scanner in the operating theater. Raman spectroscopy, which Samir Taneja was talking on our podcast about recently when he was down here. So there's a bunch of things. So give us an overview, your take on whether these technologies might, I suppose, first of all, enable the same sort of high quality intraoperative margin assessment as Neurosafe does, and second of all, the more pragmatic approaches of these technologies.
Yes, thank you. So this is a topic that really, really interests me. I've been working on this as soon as I got here because the world is changing. So basically, frozen section is almost 100 years old. And we have so many new things that we can do. And you already mentioned the most exciting ones from my point of view. So, but there are drawbacks and benefits to each of them. So Raman spectroscopy, I think it was one of the first ones that was tried. It's really exciting. It has been tried in vivo and ex vivo, basically putting a probe attached to like a laparoscopic probe with a robot to try to find the places where there's cancer remaining in the prostate bed. And also there's a machine that can look at it when the prostate is out, similar to what we do with Neurosafe. The problem with that one is just the field of view is very limited. So it takes a long time to scan a big surface of the prostate. That makes it a little bit more difficult to be feasible, and probably it will take you time to analyze the whole posterolateral bundle like you do in Neurosafe. So if it doesn't save you time, then what's the benefit of it? I think...
Although I must say, if you don't mind me saying, Samir Taneja was in Australia last week presenting an overview of this, and he pointed out that they are now using some AI technology, and they've the scan time down to like 2 minutes, and even like a yes/no answer on cancer in like a few seconds potentially. So like everything with these technologies where there's a lot of data, maybe there will be AI solutions that will speed that up. But I hear you. Yeah.
And also, if you are using some technology in real time, there's also implications for things like focal therapy, where you can just extend your field of treatment So there's some advantages in those platforms as well.
Yeah, not just intraoperative margin assessment, but lesion assessment. He was showing an example of focal cryotherapy.
That's right.
And then they were taking biopsies from adjacent and then real-time scanning and then extending the ice ball potentially. So yeah, I suspect that some of those limitations on Raman spectroscopy might be addressed. But yeah, one to watch.
Yeah. Then there's the PSMA PET machine that you mentioned. That's amazing. I haven't seen it working. It offers also a whole new world where you can also scan the lymph nodes and other stuff. However, I think that the fact that it requires PSMA and radionuclide, it's going to probably make it a little bit more difficult to implement and more expensive. But yeah, I'm excited to see the results on that technology. There's also another one, optical coherence tomography. That one is also exciting, but it doesn't give you an image. It basically gives you like a graph that AI can interpret then to understand if there's cancer in the tissue that you're scanning. And then there's confocal microscopy, which is actually the one that we have been most excited about. We have tried 2 machines. One is the first one that came out. It's called the Vivescope. That one has 2 lasers, produces really good images with a lot of contrast. It's really, really good, I think, especially for biopsies. But for a prostate margin, the problem is that it requires you to chop still the prostate and to create small sections. So the time that you gain by just doing the confocal instead of a frozen is not great. So we saw that it had still a lot of limitations. And then I think the latest one that we're really excited about is the histolog scanner. So this is a machine that sorts out most of the problems that we've seen with these new technologies. It has a massive field of view. It's almost 4 by 5 centimeters. It can scan the whole posterolateral surface of the prostate in less than 1 minute. And it gives you really nice detailed images all the way to the cellular level. So we have been trying this, and we are running, we finished a feasibility study to evaluate this technology. We have published a little bit on the accuracy, and the accuracy looks really good, almost comparable to frozen section. So yeah, you gotta watch this space. This is coming, and hopefully these technologies will allow to basically all centers be able to do real-time analysis of their surgical margins and get the benefits of this to more patients.
Very good.
I totally love it. It's just amazing. And we've been meeting with local representatives of Histolog. That's from Salmon Tree in Switzerland, isn't it? And it does look like this might help bridge the gap. Any of these intraoperative margin assessment technologies that we might be able to sort of get to the endpoint that you've delivered for the benefit of these patients in the Neurosafe Proof trial, but without having to take on the challenge of doing Neurosafe. Eoin, what's your take on it?
Yeah. My take on it is that we now see, so confocal laser microscopy has been around for a long time. Confocal laser microscopy, and particularly the Histolog machine, which we're all talking about, is in its infancy in terms of its assessment of its diagnostic accuracy of a margin. We look at the prostate in a different way. Instead of cross-sectioning it and looking at it in the traditional histopathological assessment of a prostate margin way, we look en face, okay? So we're going to have to measure margins in a different way. We're going to have to find out about it. Ricardo's work is going to shine a light on some of that. He's excited about it. He knows some of the data as well. But what we definitely do know is that if it can match the diagnostic accuracy, it's that the amount of time you're going to need to wait is going to tumble down. We're already seeing pretty reliable data that instead of 55 minutes or 43 minutes for your frozen sections, it can come down to under 10 minutes before you have the answer. So that's going to be really appealing. As with all new technologies, the price will probably come down and become more accessible. And I think that's why we're excited about it as a group, because if it democratizes access to an approach to the prostatectomy that we now show can bring about real benefits for men's recovery, then that's what we're about as the Neurosafe Proof team.
Greg, one thing about positive surgical margins is they're not all created equally. So, if you see a tiny 2 millimeter positive margin with grade group 1 disease, it may not warrant going back and completely resecting that bundle. Now, I know you had to maintain the oncological integrity of this trial, so you had to do that for trial.
They didn't. What was your cutoff for saying it was insignificant? Because they actually left a bunch of those margins.
Yeah, so we tolerated margins of less than 3 millimeters, which didn't have high-grade cancer at the margin and was only on one slice on one side. So, a unifocal, low-grade, small margin.
Yeah, I think that's really important, isn't it? And we also heard...
And didn't have a BCR penalty for it. So
yeah. And we also heard from Samir this week at USANS that there are some AI platforms that can look at prognostic indicators for that margin and prognosticate whether, what's the likelihood of biochemical recurrence based on that positive margin. And I think that's also...
And one of the other reasons we made that decision was because we knew from the literature and we knew from our own data from the feasibility study, when you do your secondary resection, when you use any cancer touching the inked margin as your trigger for secondary resection, the presence of adenocarcinoma in the secondary resection tissue is 25%.
Yeah.
So you've done your beautiful nerve spare. You're going to cost the guy erectile function recovery with questionable oncological merit. So, but I think the thing to say here is that we set up our trigger protocolized for the secondary resection, but teams can approach this in different ways. This is not a mandate, and you can be more or less conservative as you find your patient population, as you have an appetite for as yourself as a team. And also, we're continuing to look at this ourselves. Our oncological data from this study is not mature yet, and it might be that we have to think of it again. But that's the best. Yeah, that's what we hope we got it right.
Very good.
Just amazing.
Yeah.
Just amazing.
Absolutely.
It's been great to dive deep into it. Greg, wrapping it all up, there'll be a lot of digest and comment in the coming days, of course, as people look at this and read the paper. We'll have follow-up podcasts, probably on intraoperative margin assessment, I think, because this is going to trigger everyone saying, we need to do this, but we need the more pragmatic solutions. So what are your take-home points for us, Greg, as we wrap up this podcast?
Yeah, so really just to point out a couple of things that really are a credit to the research team, the multi-center team, 5 UK centres, excellent clinical and research staff contributed to this to get the study complete through 2 national lockdowns during COVID. I think that's quite remarkable, and it shows the adaptivity of the UK clinical community. Fantastic to have done that. 90% primary endpoint data completeness, that again is remarkable, and it makes the data more credible. And the final thing that I'd just like to say is thank you to everyone who participated in the study, all of the clinical and research staff, all of the committees who guided us through the study, the data monitoring committee and trial steering committees, the clinical trials unit who ran it for us, and finally to the patients who, without this, it wouldn't be possible, and who volunteered to take part in a study for altruistic reasons, which is to their credit.
Amazing. Well, we are so impressed. Congratulations, Greg, Ricardo, Eoin, and the rest of your fantastic team.
Yeah, it's just awesome. And Renu, the podcast we posted yesterday on the Translate trial, that's another UK trial, surgical trial, run during COVID, published in Lancet Oncology. And I hear from all these UK and Irish people fleeing down here how morale is so poor in the UK and the NHS, but
and yet
2 awesome randomized surgical trials conducted in COVID,
in the hardest of times. Yeah,
both of them.
Yeah,
take about
absolutely.
urology investigators in the NHS, the trial teams who support you, and of course the patients who despite the challenges of COVID and so on take part in these trials. Yeah, it's just awesome. Feel good factor on the podcast again today. So great. Well, I'm sure you're going to go and celebrate in Madrid tonight. Beers are on. Greg, I suppose. Greg, it's a senior author's duty to
You've been
buy
nominated,
the beers.
Greg.
I'll go find my credit card.
You go find the credit
Fantastic,
card.
yeah.
And that's all we have time for on this episode of GU Cast. Thanks very much again for these excellent investigators for giving us their time and joining in. And a thanks also to our teamed podcast supporter, Mundi Pharma. They're gold partners of ours and they love supporting these surgical type podcasts, even though their therapy area is in advanced prostate cancer, ADT. But Mundi Pharma are gold partners of ours and they were keen to support this type of surgical podcast and help disseminate the podcast out to our audience. So well done again to everyone.
See what else is happening at EAU. Lots of great stuff.
Let's do that. Take care.